Great. Hi, good morning, and welcome, and thank you for coming to Pediatric Grand Rounds. I am not Miguel, as everyone might notice. He is, I think, on his way to AAP, but I'm happy to pinch hit. Today's Cloud CME claim credit code is 40530. Please claim that within 48 hours. And then everyone online, you can submit questions in the live chat, and we will be monitoring them and can ask those questions of the speakers at the end. Okay, one slide. Am I going to do this right? I'm very nervous about the technology. There we go. Please nominate a safety hero when you see someone using a zero harm technique that prevents harm. Really important for us to hear those stories. Great. So I'm really happy to introduce our speakers today. We have three wonderful speakers who are passionate about point-of-care ultrasound. Dr. Benjamin Drum is an assistant professor at the University of Utah and works as a hospitalist in both the University of Utah Hospital and here at Primary Children's Hospital. He completed his residency in internal medicine and pediatrics at the University of Utah, and he serves as the medical director for point-of-care ultrasound in the Pediatric Hospitalist group. Dr. Amy Miner is an assistant professor in the Division of Neonatology. She received her pediatrics training at the University of California, Irvine, and her fellowship in neonatal perinatal medicine at Rutgers Robert Wood Johnson. And Dr. Matt Steimle is an associate professor in the Division of Pediatric Emergency Medicine. He completed his residency in emergency medicine at Wayne State University, his fellowship in pediatric emergency medicine at the Georgia Regents Medical College of Georgia, and then completed a second fellowship in emergency ultrasound, also at that same institution. He's currently the PEM Ultrasound Medical Director and the System-Wide Clinical Ultrasound Director for Children's Health. This team is passionate about point-of-care ultrasound, and we're excited to hear about how they are using, teaching, and researching this modality. Please welcome them.
Thank you, Dr. Soprano, for that introduction, and thank you to Primary Children's Hospital for inviting us to come and present today. Today we want to showcase point-of-care ultrasound and how we are advancing state-of-art care at Primary Children's Hospital using POCUS. So for our objectives today, we're going to describe the current landscape of POCUS in pediatric medicine and specifically at our hospital. And we're going to identify standardized indications as well as a standardized framework that we use for POCUS examinations in both the ED, the NICU, and the inpatient settings. And then we're going to employ some POCUS knowledge in a case, one case for each of our inpatient settings, or each of our settings, and then we're going to end by describing some active POCUS research occurring at our institution. And so just to go a little bit more in depth, we'll start with a brief introduction to point-of-care ultrasound, also known as POCUS, try and get everyone on the same page about what we're talking about. And then we will discuss the POCUS Consortium. That's a multidisciplinary gathering of POCUS leaders that has been a powerful tool to advance POCUS and align objectives across our institution. Although there are several departments that are actively implementing POCUS, including nephrology, PICU, gastroenterology, physical therapy, and many others, we are just going to focus our talk today on the three, pediatric emergency medicine, hospital medicine, and then the NICU. For each of these, we will discuss the national landscape of POCUS compared to our institution, and then we'll go through a sample case. All of the cases presented today are actual cases that occurred at Primary Children's Hospital, and all of the data has been de-identified for patient safety. We'll then end by briefly discussing, if we have time, POCUS education on both the medical student and the resident level. So what is POCUS? So POCUS is designed to be performed at the bedside and is to answer a specific yes/no question. And so this is very different than a formal radiology ultrasound. And I have a little image of our traditional workflow when we would see the patient and say, we should ultrasound something, and then we order it. The tech would go and acquire the images, or radiologists would read it, and then they would report that to the clinical bedside team, and then they would use that for their clinical decision making. And the radiologist, for example, if we ordered an abdominal ultrasound, and we're looking at spleen enlargement, they would comment on the spleen, but they would also comment on the liver and all the other organs and everything in the images that are required. Whereas in POCUS, we're not interpreting the entirety of every image. We are actually just focusing on the yes/no question. And I kind of compare this to Where's Waldo? So, you know, a formal ultrasound would have to analyze this whole image and see everything going on. Whereas in POCUS, we just have the yes/no question of where is Waldo? And so we find Waldo and we're done with the image, which is great. But, you know, we're going to miss other things that may be going on. So we're going to miss like the vacuum cleaners, the strange, colorful array of hats. We may even miss like this woman who's precariously about to fall dangerously. And that's okay. So, you know, we are not radiologists, we're bedside clinicians. And so it's important that we really narrow our scope of the images that we're looking at and stick to what our question is. And this really helps us focus on the relevant clinical question and also is protective from a medical legal standpoint because, again, we're focusing on just that yes/no question, where is Waldo? And the framework that we used to identify these yes/no questions is called the I-AIM approach. Very cute because we're aiming our ultrasound, but also informative. So I stands for indication, naming that yes/no question. A is for acquisition. Can we obtain the images that are going to actually answer that question? And then can we interpret those images? And lastly, will the interpretation of that change the management of the patient at the bedside? For example, if I had a patient that presented with sudden onset shortness of breath, I'm going to perform a POCUS procedure and ask the targeted question, does the patient have a pneumothorax? Then I will acquire an image of the pleura at the apices of the lung where I would expect air to be, and then I would interpret that image to see if it shows active lung sliding or not. And then based off of that image, I would adjust my management. Maybe this person needs a chest tube, or maybe I can rule out pneumothorax and pursue other reasons why they may have dyspnea. Some advantages of POCUS, in addition to what we talked about. So no radiation, fast results readily available, right? We don't have to wait for that traditional framework of waiting for the scan and the radiology reports. And this is really bringing clinicians back to the bedside as well. We're spending more time with patients doing the ultrasound, and we can show those images in real time, both to patients and to staff, like nurses. As you can imagine, this is relatively cheap compared to formal ultrasound or other, you know, MRI, CT, things like that. And the faster and cheaper something is, the more widespread use it'll be. And so that has positive impacts on health equity. This is outside the scope of this procedure, but POCUS is actively being used in global health because it's so portable and easy to use. And then lastly, it really enables information sharing. So we can record these images and send it to other physicians. And this could be particularly helpful. You can imagine a direct admission where a PCP has ultrasound images of a patient they're concerned about in their office and could help facilitate a direct admission or a fast emergency room visit with focused questions. So now that I've introduced POCUS and the I-AIM framework and its advantages, Dr. Steimle will go through our emergency medicine data.
Thank you, Dr. Drum. Yep, just to recap what Dr. Drum said, POCUS is very specific. It's a yes or no question. Is there a pneumothorax? Yes or no. Is there a pregnancy? Yes or no. Is there a pericardial effusion? Yes or no. So it's just a yes or no question, a binary question. Please, if you have any questions at the end of this, please email me. My email is listed there. All right, so I'm going to talk about some of the key national guidelines and foundational literature very briefly, just to save our time for other things, and resources that you'll be able to find here at a later time. I will summarize some of what has happened at Primary Children's in the PEM department with POCUS. I will illustrate kind of how this has come to be. This does take years to develop, usually takes a few years. We've been working on this for 10 years. So it does take many years to build a POCUS program. We'll look at a case, a cardiac POCUS case, and then we'll show some of the things that we have been able to do over the last 10 years with education and quality assurance, et cetera. This was a big policy statement that came out in Pediatrics in April 2015 that really changed the landscape of pediatric emergency medicine, really pushing for all PEM doctors to learn POCUS, especially in fellowships, et cetera. These are some other key papers that talk about how to get credentialed and how to document and consensus applications. Great resources here if you want to look at these at a later time. Some really excellent resources are the P2 network, P2SK. You don't have to recreate the wheel for all of those of you who are building POCUS programs. There are hundreds of lectures online, high quality lectures that you can use to teach your residents and fellows, et cetera. ACEP.org has, I think I counted 20 or 30 resources on there, so that's a great resource as well as the emergencyultrasoundteaching.com. A lot of free online resources. So the background at Primary Children's and talking about the POCUS Consortium, we'll review a little bit of a timeline. In the early days, in 2010 to 2016, our PEM fellows went to the University of Utah and did an external rotation in emergency medicine to learn POCUS. In April 2015, this policy statement came out and said that PEM should be teaching and doing POCUS. In 2015, we established an ultrasound medical director, which is key in building a POCUS program. You definitely need to have a person that will be your ultrasound medical director. We began internal training in 2015. 4 attendings started training. Dr. Soprano was actually one of the first 4 in 2015. We had ultrasound educator, Sasha Gordon, who helps all of us significantly in teaching POCUS. 2016, we acquired an ultrasound machine with 4 probes. In spring of 2016, we started teaching our fellows internally POCUS at Primary Children's. They weren't going to an external facility anymore. Our first group of attendings received privileging in 2016. We started a resident elective in 2016 for POCUS. We started to get administrative support, which is very important for building POCUS to help with calendaring, scheduling, paperwork. We started collaborating with radiology. Radiology did help the PEM department do quality assurance in 2016 and 2017. They wanted to be involved with the quality assurance oversight. 2017, we started retention rounds as we realized that the physicians that had received training needed to have ongoing training every 2 years to maintain their POCUS abilities. As of 2017, radiology said, no thanks, we don't want to do your quality assurance. We do our own, and you guys are capable. And so since 2017, PEM has been doing all of their own quality assurance. We did have an associate ultrasound medical director come to help, Dr. Matthew Chadkowski, to help build the POCUS faculty. The fellows stay at Primary Children's. In 2018, we started the POCUS Consortium, which I will talk about in the next slide. In June of 2018, we started the first NICU, PICU, Society of Critical Care, Neonatal Fundamental POCUS Conference, an internal conference that started that year. We started to do research and quality assurance in 2018. And we had a second ultrasound medical, associate medical director start, Dr. Sydney Ryan. All right, so talking about the POCUS Consortium, we realized that many of us in the NICU, the PICU, and throughout the hospital were building POCUS programs, and it made sense for us to work together to collaborate. And so we came up with this mission statement: through multi-specialty and administrative collaboration, we will use point-of-care ultrasound to optimize patient care. We will provide leadership to advance POCUS through education and training, quality assurance, research, technology advancement, administration, and clinical practice. The POCUS Consortium members, you can see multiple divisions: PEM, NICU, PICU, SICU, Pediatric Hospitalist, Radiology. We have POCUS advocates in radiology and cardiology, administrative faculty. And then Ben mentioned we have GI, nephrology, hematology, PM&R. Other divisions are performing POCUS. And I do want to take a moment to thank all of the division chiefs that have been so supportive. To have a successful POCUS program, you need to have a division chief that supports POCUS, that realizes that you will need FTE, you will need time to build something. And all of the people that have helped us over the years, the administrative assistants, the fellowship directors, You definitely need to have support from your fellowship directors and your residency directors to make POCUS sustainable. So continuing on with the POCUS timeline, we continued to teach the fundamental course. We gave, some of you may remember, we gave a grand rounds presentation similar today in 2019. Medical student elective started in 2021. We were teaching our global rural underserved children healthcare fellows POCUS, but because of COVID, we had to slow down teaching them. In 2021, we did obtain the True POCUS EC, which stands for Tribal Rural Underserved POCUS Educational Collaborative with the HRSA grant. We had 7 partner sites in different states, Utah, Wyoming, Nevada, New Mexico, and have been teaching POCUS outreach to these locations. We've started to do several national presentations at PEPIC and P2, continuing to do many poster presentations as well. We've now had 6 of these neonatal fundamental POCUS conferences that have happened since 2018 that bring in a lot of internal people and external people from all over Utah and other states. In 2023, one of my fellows, or our fellows, Kaisa Vlasic, started a POCUS educational project in Tanzania. We started to do a PEM POCUS boot camp in 2023 and have done some collaborative outreach in Jerusalem with Dr. Brandon Kirkland. In 2025, this year, we established a system-wide clinical ultrasound director for children's health so that they can have some leadership as other divisions build POCUS programs. And then today, we're giving this grand rounds presentation. So I'm going to share a couple statements from that policy letter. Why is POCUS being taught? Point-of-care ultrasound is increasingly being used to facilitate accurate and timely diagnosis and to guide procedures. It is important for pediatric emergency medicine physicians caring for patients in the emergency department to receive adequate and continued point-of-care ultrasound training for those indications used in their practice setting. Emergency departments should have credentialing and quality assurance programs. PEM fellowship should provide appropriate training to physician trainees. Hospitals should provide privileges to physicians who demonstrate competency in point-of-care ultrasound. So who is receiving POCUS training? It's for our PEM fellows, our global rural underserved children healthcare fellows, our attendings, APPs, nurses, residents, medical students, and then we have several outreach sites listed up there in Lander, Wyoming, Uinta Basin, Tooele, 4th Street Clinic, Utah Navajo Healthcare, Chinle, and Shiprock. Who is teaching POCUS and PEM? Myself, Matt Chadkowski, Sasha Gordon are the primary POCUS faculty. What is being taught? We have a curriculum. PEM attendings can obtain POCUS privileges. They receive 10 hours of online training, 1 hour of testing, 3 hours of simulation, about 8 hours of hands-on, 2 hours of independent, so about 24 hours to obtain POCUS training if you want to receive privileges. They have to complete 20 scans every 2 years and get 4 hours of CME every 2 years to maintain it. And basically our residents and medical students do this over a 1 to 2 week rotation. Training occurs on their own computer at LDS Hospital in the Sim Center using the Symbionics and the SonoSim machines. At Primary Children's Hospital in the RTU. QA portion occurs in our teleconference room. Training is ongoing. It's a 6-month longitudinal experience for our fellows. We are transitioning this year to an intensive 1-week course. We do 3 to 4 ultrasound case conferences on the first Wednesday of the month at 10 a.m. CME can be attained and all are welcome to attend from other divisions, as well as if anyone wants to attend our QA session, which we do every month, you're welcome to attend. We have our annual PEM POCUS boot camp. You're also welcome to attend that. For our fellows, this is required, part of their educational curriculum. For our attendings, it is optional. The residents, it's optional. Medical students, it's optional. So looking at some of the data that we've collected, in the first years from 2017 to 2019, the main types of POCUS scans that we do are focus, cardiac, and IVC for about 30% of the scans, soft tissue for 25%, EFAST for 18%, and lung. So those are the main uses that we use POCUS for in those years. In those early years, training and education scans were about 53% of the total scans, and then patient care clinical decisioning scans were 47%. From 2017 to 2022, you can see that we had 1,200 scans. 51% were educational, 49% were clinical. From 2022 to 2025, we have switched to mostly being clinical scans, doing 83% are now clinical, 17% are educational. So learning from this, the first several years, the first 5 or so years are going to be mostly educational scans to get people learning POCUS. But as you develop your POCUS programs 5 or 10 years in, you will get to a point where you're mostly doing clinical scans and less educational. Looking at all of the data from 2017 to 25%, you can see that our 62% are clinical scans and 38% are educational. Looking at just the Lehigh data, the main indications at Lehigh are cardiac, soft tissue, lung, and EFAST. They're the same indicators, same things we're doing in Salt Lake. And then kind of putting all of the data together, once again, cardiac, soft tissue, lung, and EFAST are the main scans that we're doing. To have anything be successful, you need to have internal organization and external organization and infrastructure. Otherwise, POCUS just can't be built. You need to have resources. Your fellows and attendings should have a designated system to store their clinical images and log their educational scans. You need to have dedicated administrative support. It's crucial to maintain these records and manage these records over the years. This is what we do. We use U-Box. We have folders for our fellows, for our PEM physicians. We keep our ultrasound documents, boot camp documents, financial reports of the ultrasounds. We meet quarterly. We keep all of those notes, et cetera. So you need to have somewhere, a repository to store all of your POCUS resources. I did show, this is our fellows. They each get their own folder where they can keep all of their POCUS resources. And within their folders, that we keep track of their clinical scans, their educational scans, their POCUS quizzes and tests, their quality assurance scans, and their CME, so that when they graduate, they can take this to get privileges or apply for privileges. The fellows get this fellow curriculum task checklist. They get an ultrasound binder. They do their survey. They watch their videos. They have their quizzes. They have to do 25 EFAST and 25 cardiac. 5 of each of those need to be independent. They have to attain a quality assurance session, give a presentation, do some surveys, et cetera. So having a very organized electronic place to store all of their POCUS work. And then we do the exact same thing for our attendings. You can see that each attending has a box that they can keep all of their POCUS documents, et cetera. So being organized is key to building your POCUS program. We use for documentation, how do you document your scan? In the emergency department, we use the recommendations by Marin. And this is an example. This one is a reporting guideline for ultrasound evaluation of the heart and inferior vena cava. You need to record patient demographics, examination demographics, indications for the exam, the views that you're going to obtain, your findings, your interpretation, and then you need to have a quality assurance that's linked to this. So this is the documentation we use, and this is published in the Marin document. As I stated earlier, we have been doing our own quality assurance since 2017. As of February, we've done approximately 1,800, 1,900 scans at both Salt Lake and Lehigh. So my case is going to be a cardiac case, so I'm just going to spend 1 or 2 minutes reviewing cardiac ultrasound in brief. So parasternal long axis, we teach the standard emergency medicine way. There are 2 ways to teach ultrasound, the cardiology way or the standard radiology way. The difference, I put the clock face up there. We talk about everything in the cardiac around a clock. If you're using emergency medicine, you typically have the probe indicator pointing towards 4 o'clock, but if you're teaching in the cardiac way, it's usually pointed towards 10 o'clock, but it's the same axis. So you put your probe on, you'll obtain a view like this. You'll see the left atrium, the left ventricle, the left ventricular outflow tract, the aorta, and the right ventricle. I'll just show you a video here. You can see the anterior leaflet of the mitral valve is slapping the septum. This can tell you quickly that you have normal systolic function. Just looking at that again, the anterior leaflet gives a high five to that septum. You also know that the right ventricle, the aortic outflow, and the left atrium are all approximately the same size. That is another indicator that you have normal systolic function. All right, so peristernal short axis, we point the probe indicator towards 8 o'clock. You can see here, this is at the level of the papillary muscles. You can see there's good squeeze circumferentially. Some people call this the croissant on the bagel. The right ventricle looks like a croissant, and the left ventricle looks more like a bagel or a donut. And then we'll talk about the apical forechamber. The probe indicator will be at 9 o'clock. I'm not sure if I have their pointer, a laser. Oh, mouse. Okay. Okay. So where the mouse is, this is left ventricle, left atrium, right ventricle. You can see once again that anterior leaflet of the septum is smacking the septum, which is normal. So this is a sample case that happened in April of this year. A 17-month-old female came in with increased work of breathing and vomiting 6 times in the last 24 hours, no blood, no bile. She saw her PCP the day prior and was diagnosed with the viral syndrome. She didn't want to eat. She had 4 wet diapers, no change in her urine or stool, no fever. She's coughing and is congested. She just wants to be held and cuddled. On exam, she's tachycardic and tachypnic. Her lungs are clear, but she is belly breathing and grunting with tachypnea. She is tachycardic. She has a gallop. Her capillary refill is 3 to 4 seconds. Once again, she has increased work of breathing, congestion, tachypnic, and PEL. Suctioning was not helpful. She has a normal neurologic exam, normal abdominal exam. At times, she will desaturate into the 70s, so she's placed on blow-by oxygen. So far, her respiratory exam and cardiac exams are abnormal, so you decide to get a POCUS, an EKG, and a chest X-ray. And this is her image is this image. This is normal peristernal long. And reviewing, when you look at this, you should be able to determine the global ventricular function. Pick one of these categories. So we will go ahead and play these videos. So you can see the anterior leaflet here is barely moving. There's not much squeeze at all. Remind yourself of what normal looks like. So that anterior leaflet should be smacking the septum, which it's not. You can see that that left ventricle is dilated and there's not good squeeze. If you look at the squeeze over here in the apex, you can see that there's good squeeze there. There's not very good squeeze. So looking here, you would pick one of these. I would pick severely reduced global ventricular function. We'll look at peristernal short. Once again, you can see the papillary muscles over here. There's good circumferential squeeze. This is a left ventricle. This is her heart. You can see that there's not very good squeeze. The right ventricle you can see. So once again, I would pick severely reduced global ventricular function. This is her apical 4. Once again, you can see normal. Down here, you can see the annulus, which is where the tricuspid valve lies, the annulus of the mitral valve. They're moving to and fro this way really well. You're seeing that there's not much movement of the annulus. There's not much squeeze compared to normal. So once again, I would pick severely reduced global ventricular function. So you'd fill out your sheet, you're documenting, you're going through the things. So global ventricular function, severely reduced, pericardial effusion absent, right ventricular size, indeterminate. You don't want to comment on that. You don't feel comfortable with that. Left ventricular size looks dilated. We didn't look at the IVC, so we'll skip that part. So we would call this an impaired global ventricular function for our interpretation of the scan. And a dilated left ventricle. So reviewing the indication that Dr. Drum mentioned, our indication is she had respiratory and abnormal cardiac exams with a gallop, that you had concern for heart failure, and you wanted to see if she had heart failure. That was your yes or no question. You wanted to see what her heart was doing. So you get cardiac and lung images. I actually did get lung, this was not my patient, but they did obtain lung images, which I'm not showing because Dr. Drum is going to talk about lung ultrasound. But on the lung ultrasound, there were B lines, which is abnormal, decreased cardiac function. So we have decided, based off of the POCUS, that it's concern for heart failure and volume overload, specifically pulmonary edema. We urgently consult cardiology and tell them the POCUS shows decreased cardiac function and B lines suggestive of pulmonary edema. So we put it all together with the chest x-ray. Interestingly enough, the chest x-ray by the ER doctor, they read it as slightly enlarged cardiac silhouette. Radiology read it as normal, heart and mediastinum within normal. They did mention central, interstitial, and airspace densities and small bilateral effusions. Main differential considerations would include viral or atypical pneumonia versus pulmonary edema. EKG showed sinus tachycardia and some abnormalities on the EKG listed above, LVH, etc. Her labs, you can see listed there. She had rhinovirus, so her heart failure was probably induced by rhinoenterovirus. Cardiology asked for troponin, BNP lactate. You can see the troponin and BNP are very elevated. She was started on BiPAP. Cardiology performed their own ultrasound, started milrinone for heart failure, went to the SICU. She spent 5 months in our hospital, diagnosed with lymphocytic myocarditis on LV muscle core. So using ultrasound for cardiac can just help you get to your diagnosis much quicker. The chest x-ray was not that helpful on this patient. You saved time. You were able to narrow your differential quickly. So just to review our dissemination, so far we have had 34 fellows trained in POCUS that have gone through the training. You can see their names listed there. We've had 28 attendings who've gone through the training. We've had 24 residents take the elective, 13 medical students. There are some documents coming out now that state that you should, as POCUS becomes more widespread, there is a pressing need for structured leadership and collaboration to ensure its effective integration, ongoing use, and sustainable growth in pediatric care. They advocate for a system-wide clinical ultrasound program development, and it mentions these different things that a system-wide clinical ultrasound director should do. They should provide oversight for the clinical ultrasound committee, oversight of training, quality review, documentation, equipment. We have put out a few things since we've been here. An article in 2016. We've had a few different fellows put articles in Emergency Physicians Monthly using POCUS, and we've put out an article in JAHSE, Increased Pediatric Resident Confidence in Point-of-Care Ultrasound after an ultrasound elective. This one was on-site pediatric and neonatal point-of-care ultrasound course led by multidisciplinary local experts, may promote sustainable clinical POCUS integration. We had some residents go to AAP last year, and they actually won the poster contest with this ultrasound case in Florida. We have our boot camp that we do. The NICU and the PICU have this excellent ultrasound course. And then we have been fortunate enough to present several presentations and workshops, not all listed. Some of them are listed here in the trial rural underserved setting. We have some future studies that one of our fellows is working on, sepsis with POCUS, Noreen Shehab, a quality improvement project. Dr. Drum and I are working on a study on parental satisfaction with POCUS. And those are my slides. Thank you.
Thanks, Dr. Steimle. So we'll go through very similar metrics with hospital medicine. Hospital medicine is a little bit of a newer specialty in terms of adoption of POCUS, but there was this article that came out just in July of 2025, 3 months ago, national survey published by the AAP on point-of-care ultrasound. They looked at 97 programs, 54 responded, so they had 54 responses. 9 of the 54 had POCUS, so 1 out of every 6. In terms of location, as you can see, no one from the Mountain West or West responded, so we're not totally included. But in terms of the program setting, if we look at freestanding children's hospitals associated with a university like ours, 6 out of 19, 6 had POCUS programs, 19 did not. So 24% of freestanding children's hospitals associated with a university like ours actually had POCUS. So still quite a minority, 24%. If you look at the indications of what is happening with, how people are using POCUS in the hospital, a lot of it is procedural. So lumbar puncture, we'll talk about that a little bit, and then pleural effusion and chest tube management. And then there's some other indications you can see here in terms of heart, lungs, things that Dr. Steimle talked about. I highlighted bronchiolitis because you can see only actually 2 of the 9 programs are using POCUS for bronchiolitis, and that's what our case will be about. In terms of barriers, so nationally, like I said, hospital medicine is a newer specialty in terms of POCUS implementation. So we have several barriers, issues with equipment, local support, lack of experts, lack of robust guidelines to guide us. And so these are things that nationally we're all working through. In terms of the guidelines we do have, so similar to that 2015 article that Dr. Steimle had for PEM, there was an article in 2019 for specific to hospitalist practice. One of the quotes that I really love from it said that POCUS has the ability to provide real-time valuable information that could alter diagnosis, treatment, and management practices in pediatric hospital medicine. And they actually listed a good amount of indications that they felt like had a decent amount of evidence to implement even in 2019. So you can see there's lung, cardiac, abdominal, some procedural stuff, renal, bladder, etc. I won't go into this, but we do work closely with cardiology to make sure that we are having clear boundaries with our ACHD kids. So the American Society of Echocardiography released really clear guidelines about how POCUS can be used in our cardiac kiddos. And then, like I talked about for ultrasound, there was a 2024 systematic review that was also published with the AAP that found that POCUS improved first attempt success rates of LPs. So obviously that decreases repeat LP attempts, length of stay in the hospital, time to antibiotics, harm from missing the LP, hematoma rate, all of those things. So in terms of what we're doing locally, very similar to PEM. So we have a privileging pathway. Here's kind of what's included, but it's heart, lung, belly mostly, and then some procedural stuff, abscess, cellulitis, lumbar punctures. Someone in our group does PICC lines. And so if we look at kind of the indications that we are teaching and implementing here at Primary Children's versus the national guidelines, we are really getting almost all of the indications that are being endorsed by the AAP. In terms of our privileging pathway, so again, very similar to longitudinal pathway, 5 to 6 half days, about 1 per month over 6 months. It has about 13 hours of in-person scanning at Primary Children's Hospital. The curriculum is matching, obviously, what we want people to be credentialed on. And we actually use our 4th-year medical students who are in the honors pathway as adjunct teachers. And we have active research in terms of using them as experts to help teach us. In terms of our timeline, so August 2023 is when our pathway was established. Spring 2024, we had our first cohort, so 8 hospitalists were trained. We incorporated fellows that next fall. In the winter of 2025, we had our first POCUS lunch conference, which went through cases from our own institution. We presented our work nationally at PAS in the spring. Got a dedicated ultrasound machine. We had been using a loaner from the adult ED before that in June, and then had a funding for a POCUS medical directorship for hospital medicine come July. So in summary, you've had 3 cohorts trained, which is 15 hospitalists, 2 fellows. 10 of those hospitalists currently have privileges and are actively scanning, and then we're actively training the next cohort now. So 4 hospitalists and 2 fellows are currently underway in their training. And we're hoping to do probably 4 to 6 hospitalists every 6 months, just with the demand and the amount of new hires that we've had in our program. So going into our case, so we took care of a 16-month-old male, global delay, scoliosis, G-tube dependent, presenting with RSV bronchiolitis. As you can imagine, with scoliosis and delay, has had previous hospitalizations for bronchiolitis that have gone longer, but now he's getting a little bit older. Still admitted on day of illness 5, I believe. Now we're at day of illness 7. Came in and saw that his oxygen needs an increase over the last 24 hours. So at home, he's healthy, but when he's ill, he's allowed to be on 0.5 liter to 1 liter. He was admitted 1.5 liters, and then he actually went up to 3.5 liters overnight. And so let's use the IAIM approach to think about how we could use ultrasound for this kiddo. So the questions I thought of that could be helpful. So is this patient now developing a bacterial pneumonia, right? He's at day of illness 7, kind of the time that we think that things might get worse. So does he need a repeat chest x-ray? Does this person have a progressive worsening or a new viral pneumonia? We know that kids catch other viruses all the time in the hospital, unfortunately, despite our best precautions. And then also, how long does this patient need to be in the hospital, right? So he's on day of illness 7. If nothing else is going on, maybe things are peaking despite what we see from overnight data. So in terms of how we acquire these images, sorry, the slide stopped advancing. There we go. Okay. So we're going to use some lung ultrasound, and we're looking for A lines versus B lines, which we'll talk about, subpleural consolidations, which I'll talk about, and then if someone has a new pleural effusion, that would be suggestive of a bacterial pneumonia as well. So in terms of a brief intro to lung ultrasound, so we have rib shadowing on the left and right here. And then we've got the bright line is the pleural line. And then everything, ultrasound does a great job of imaging solid structures and semi-solid structures, and unfortunately attenuates dramatically in air. So as healthy lungs are composed of air, pretty much everything we learn on lung ultrasound is looking at lung POCUS artifacts. And so there's one artifact that I'll talk about called A lines. And so this is essentially when the ultrasound waves are coming, because the pleural line is so bright, sometimes you'll get double bouncing or triple bouncing. And so the ultrasound won't be able to see anything beyond the pleural line because, again, the ultrasound waves are attenuating dramatically in air. And so instead, the ultrasound will fill in the gaps, and it fills in the gaps by imagining or visualizing that there is more pleural lines in the healthy lung. And so all of these horizontal lines going down are kind of artifacts of the pleural line that the ultrasound is imagining, but it shows us that it's just air underneath the pleura. So this is healthy lung. And then in contrast, B lines, it's a little bit controversial exactly why B lines happen, to be totally honest, but the ultrasound wave gets trapped either with a water particle or in an intralobular septa, and it gets trapped and bounces around the air and then will come back at random frequencies back to the ultrasound probe. And so rather than creating these segmented lines, it creates a vertical line all the way down because it's kind of randomly coming back and creating the solid line. So this is what B lines look like. So these spotlights kind of from the pleural all the way down. This is several B lines. More than 3 or more is considered abnormal in one pleural space. Oh, what was that? Okay. And then we also look at subpleural consolidations. So these are breakages in the pleura, and these are actually like areas of infection or inflammation, but in this case, infection that we would be seeing actually on the surface of the lung. So this is our patient's right lung. And you can see some rib shadows and then this healthy pleura. And then the very end of this right screen, you can actually see the diaphragm because a little bit of belly is kind of coming up into the screen. I know it's a little bit hard to tell, but this all looks very healthy. You can see kind of that breakage where the bright line ends and the grayer line is actually the very base of the lung. So, and then the left lung is here. And you can see there's actually a subpleural consolidation here that we're focusing on. So the very left of this image has kind of a more healthy pleura, and then that cavitation is the subpleural consolidation, and that's also right at the lung base. And this is 0.7 centimeters when we measure it. And so again, a marker of the bronchiolitis. We're actually visualizing the bronchiolitis in this kiddo. And then lastly, like I said, we looked at if there is a new pleural effusion. And so here's some abdominal organs. We're looking at the diaphragm. We're using a higher penetrating probe here so we can see deeper into the body. And usually we can see spine really well through the liver and spleen, because these are solid structures that can allow the ultrasound waves to visualize all the way to the spine. Like I said, air does not allow that to happen. And so air will actually prevent you from seeing through to the spine. And so the spine will go away as soon as you see healthy lung. And so here's an example. Here's our patient actually. So you can see here, you've got liver and spleen, and then you see those two solid, right here, these two solid pillars are the spine, and then this is lung. And you can see as the patient takes a deep breath in, you can no longer see those spinal columns because air is obstructing your view into the spine. So this tells us that there's no liquid at the base of the lung or no consolidated lung that's allowing you to see through, and this would be healthy lung. So again, we saw no effusion, but we did see a 0.7 centimeter subpleural consolidation, and we saw no B lines either on our patient. So in terms of putting this together, in terms of how we interpret our findings, I'll go through 3 studies really quickly. So there was a study that looked at 87 kids with bronchiolitis and looked at POCUS versus chest x-ray compared to expert clinician review. This was done in the UK, so they used British guidelines. But they found that lung ultrasound was essentially more sensitive and about the same specificity as chest x-ray. And notably, as you guys all know, if you've taken care of bronchiolitis, fever, O2 sats, white blood count, CRP can give you no information in terms of if someone is developing pneumonia in bronchiolitis, because they're already high and they're going to stay high. So chest x-ray, like I said, fairly sensitive and specific. Lung ultrasound, actually more sensitive, but really similar to chest x-ray. They also had this other study. This was in the ED population, but would kind of transfers to our patient here. All these patients presented with dyspnea would have received chest x-ray as their standard of care. And so in the experimental arm, they had patients get a lung ultrasound first by a physician, and then the physician could decide, do they want that chest x-ray still or not? In the control, everyone just got the chest x-ray they would have had otherwise. They found that in that experimental arm, there was a 40% reduction in the amount of chest x-rays that were performed. So either people could rule out or rule in pneumonia and didn't have any ambiguity. For novice POCUS, that was 30% reduction, and for patient or physicians who were really experienced in POCUS, that was a 60% reduction. And when they followed these patients up, there were no cases of mixed diagnoses, adverse events, or unscheduled healthcare visits. So they didn't miss any of the the pneumonias by skipping the chest x-ray. And then lastly, we're looking at hospital duration. So this was another study in the inpatient study in 150 almost infants with bronchiolitis. And they did a multivariate model, kind of a regressive analysis to see what predicts progression to CPAP, BiPAP, PICU level care. And they found that a posterior consolidation greater than 1 centimeter was the biggest predictor of if someone needed to stay in the hospital and if they were going to progress to the PICU. Sensitivity was 90% almost. And so good high sensitivity means you won't send home a patient accidentally and miss them kind of worsening at home. And so for our case, we did not order a chest x-ray in the morning. We got that ultrasound. We were reassured. We showed the images to family and the bedside nurse. Everyone felt really good that this person wasn't developing a new bacterial pneumonia or new viral pneumonia. And actually, over time, they were able to wean back to their 1 liter later that morning. They're actually discharged that afternoon, and they did not require readmission. So a really nice way where POCUS was able to change management and ensure that this patient didn't require more hospital days and more interventions. Lastly, really quickly on dissemination, like I said, we did present nationally at PAS about how we're using 4th-year medical students to help augment our expert chain and save physician expert hours and time in terms of training and getting a robust training quickly to try and privilege as many hospitalists as possible. And we're currently writing that up. So now I will turn it over to Dr. Miner to talk about the NICU.
Thank you. So, well, I'm not as tall as everyone else, clearly. Okay. So in a recent article, the National Neonatal POCUS Collaborative, in referring to POCUS in the NICU, stated, it has emerged as the new clinical tool. It is displaced, sorry, I have to find my, here we go. It has displaced in some way the classical stethoscope. And I'm really excited to present to you in the time that we have left a little bit about how important POCUS has been in the NICU. Unlike my colleagues in the NICU, POCUS is relatively new. So when I started almost a year ago looking for guidelines, for resources, any information to kind of guide me in growing and developing our program, I was really disappointed to find out that there were no national guidelines and that international guidelines, the first international guidelines, had only been published 5 years ago. So that's how new this is. And here's just a few highlights from the international guidelines. POCUS in the NICU is a focused assessment to answer a question, differs from a diagnostic study. It is not to be used to screen for congenital heart defects, but the role is dynamic. It is the same provider who performs and interprets the study and then rapidly integrates this information with the current clinical setting and then repeats the study to identify the response. So then 1 month ago, this is cutting edge. I'm so excited. 1 month ago, the first national guidelines for POCUS in the NICU were published. And wait, I just want to say one more thing here. So my objective here today is not to convince you to use POCUS, and it's not even to get you to embrace the idea of POCUS, but rather my objective is to inform you of the indications for its use, which are backed by clinical evidence. And that's why I'm so excited about POCUS. So this is just a representative of the guidelines. I didn't put this up here for you to read it, but I just want to point out a couple of things. First of all, the recommendations are divided into 2 categories, diagnostic and procedural. And then most importantly, this collaborative based each of their recommendations on evidence and used the strength of that evidence to inform the strength of those recommendations. So indications that are based on a level of evidence A, the phrase is used, POCUS is recommended. When it says POCUS is helpful, these indications have been based on a level of evidence B, and any recommendation that says POCUS may be used is based on a level of evidence C. So just knowing this really helped give validity to me for these recommendations and really helps as I decide how to prioritize how we're going to institute all of this. And then further, the authors categorize these indications by scope of practice. Basic indications, those are ones that are commonly used in the NICU, should be able to be mastered by fellows before they are complete their training. And most importantly to me, they're intended to serve as a foundational framework for developing a core neonatal POCUS curriculum. And then advanced indications are ones that require more training. So POCUS is recommended for the following: for a basic scope of practice. Again, these are the ones that are based on the highest level of evidence to assess for pneumothorax, to assess umbilical venous catheter tip position, to assess PICC line tip position, to guide peripheral vessel cannulation, and to assess landmarks and identify sites for performing lumbar punctures. And then advanced indications are for use in diagnosing transient tachypnea of the newborn and to diagnose RDS and assess the need for surfactant administration. And then just quickly, those that are based on a level of evidence B, for basic scope of practice to assess for pericardial effusion, for pleural effusion, to guide chest tube insertion, to confirm the ET tube position as intratracheal, and to guide paracentesis and pericardiocentesis. And then those that require more training for use in diagnosing pneumonia, assess the severity of lung disease and the likelihood of progression to BPD, very important in the NICU, and then to confirm the depth of ET2 positioning. So this this came from the AAP, and this is a chart that just helps, I think, further clarify the objective of POCUS and delineate it from the use of standard ultrasonography. So the main scope of POCUS in the NICU is to answer a focused clinical question in real time and guide immediate intervention. It's focused on pathophysiology, triggers immediate intervention, and it is short and focused. Unlike my colleagues, like I said, NICU, POCUS in the NICU is very new. This is the extent of our timeline. I won't go through it because I want to get really quickly to the case. I just want to kind of showcase how important POCUS is in the NICU, how rapidly it makes a huge difference. So I'm presenting this case as a timeline, so you can see along the bottom the mean arterial pressure, and each of these points loosely coincides with whatever will come above it, so you can kind of follow along. So this is the case of a 40-week, 1-day infant born via stat C-section, low APGARs, required some respiratory support, then went to room air, was evaluated, decided that this baby qualified for moderate HIE, needed therapeutic hypothermia. They placed umbilical lines. EEG showed some seizures. And this is just the initial chest x-ray. I'm just going really fast because I want to get to this. Fast forward, day of life 3. So at midnight on day of life 3, the team noticed that the mean arterial pressure trends were really, really downtrending. Now we're in the mid-30s. They decided 45 minutes later to stop Precedex. No improvement. So then at 01:38, they thought, well, maybe this is a hypovolemic situation. Maybe some fluid would help. They gave fluid, did not help. Then at 2:13, worsening hypotension. They gave another bolus. They saw that the pressure actually went down after the bolus, started epi, did a septic workup. And so now their pressures are in the 20s. They grab the ultrasound machine. And before I show you the images, of course, we use the iAIM. Here are the questions. And let me just make a very quick disclosure. Our program is not as developed. We have a lot of areas in which we can really grow, and I'm really excited about that. But one of the things that we're not good at is the whole process of placing the order, saving the image, uploading it to the EMR. So these images that I'm going to show you are not from this case. We didn't save them, but this is what it would look like. And very quickly, I'm going to jump ahead there. All of this fluid here, this is the apical 4-chamber. We look at it flipped upside down from what you saw, but essentially left side of the heart, right side of the heart. All of this around here is fluid. So we have a pericardial effusion. We used this to answer the question. Yes, it was an effusion. And these are the pictures from the case. They got out 22 milliliters of fluid out of a 3-day-old term infant. This is a lot of fluid. And then if you look here at the bottom, I've outlined the blood pressure. You can see the moment that fluid was taken out, the incredible improvement. This is acute. This is very fast, and it is life-saving. So I will just end with that. I have a lot of more really great information that I'd be happy to talk to anyone about. Please reach out to me, but I'm just so excited for this opportunity. Thanks.
Okay, I think we have like 1 minute for
We have,
questions.
yes, we have 1 minute for questions.
With new faculty coming coming in from other places that may have POCUS certification at their other place, how is it going and bringing them into our fold? Do they come in with folders like you have organized in some of other training programs? Or do they not? And then you have to kind of, put them through some sort of credentialing process here. How is that translation working?
For PEM, so if they don't have a letter, we have them reach back to their ultrasound director to write them a letter of what they've done, and we've had 2 or 3 of these happen. They have a letter that's written that says this doctor did this many EFAS, this many cardiac scans, etc. And if they meet the recommendation of primary children, they get POCUS privileges. That's it. If they've only done half, then we make them get to the number we require.
Yes, similar. We have a standardized process for that. So.
I know we're just at time, but I just want to thank you, Matt. You're the one I've worked with in emergency medicine for what you've done to improve my skills in my career, and I'm sure your colleagues would say the same thing in your areas as well. It's been a huge help and confidence builder. Thank you.
Well, thank you for teaching us. We learned about IAIM. We learned about answering a yes/no question, and that persistence and hard work builds a program. Thank you for everyone online. Remember your claim credit code 40530. Thank you.